Hi, I'm Joanna Cassidy. I'm a student at UMass working on my graduate certificate in nursing education and will be completing a patient teaching project at Holyoke Medical Center this spring. I will educate adult, non-pregnant patients on medications to help with smoking cessation and am making this video for providers to make you aware of the treatments I will be teaching patients about. I'm also a tobacco treatment specialist with training through Mayo Clinic. In an effort to conserve time, I'll move quickly through the slides. Everything I present is evidence-based, and all of my resources are listed on the last slide if you want more information. Also, feel free to email me, or you can ask me in person when I'm at HMC. Okay, why am I doing this? Why is it important? Smoking makes people sick, and the US is among countries where the share of deaths attributed to smoking is really high. So we have lots of opportunities to help patients here. Smoking is only second to hypertension and death by risk factor, and it's the highest preventable risk factor. This image follows the neural pathway of nicotine addiction. People who smoke know it's bad to smoke, and many, probably most, are ashamed that they haven't quit. You may have heard of freebasing cocaine to get higher, and that crack cocaine is also mixed with the base, making it hyperaddictive. Well, cigarette companies have done the same thing with nicotine. They've added chemicals to freebase the nicotine so people get more addicted with less exposure. On the right are study findings showing that most people who smoke want to quit, 75 to 80%. Half of smokers attempt to quit each year, but nearly all self-initiated quit attempts fail. Nicotine withdrawal and cravings are what makes it really hard to quit. This chart shows smoking abstinence with Varenicline versus placebo. Look how quickly people relapse. Nicotine withdrawal starts in about 90 minutes, peaks in about 2 to 4 days, and lasts around 3 to 4 weeks. And you can see in this chart that half of people relapse really quickly, even before that first week. And then by 4 weeks, the relapse rate drops slower. That aligns with the end of withdrawal. Nicotine cravings, however, last for months and sometimes years, which is why relapse continues even after withdrawal has ended. Symptoms of nicotine withdrawal include depression, insomnia, feeling anxious, frustrated, or angry. Patients who are withdrawn from nicotine are generally miserable. The remedy is nicotine. Treating patients in the hospital with nicotine replacement therapy relieves their suffering and provides the opportunity for them to experience smoking cessation without unmanageable withdrawal symptoms and cravings. The HHS 2008 Tobacco Use and Dependence Guidelines state first-line medications are long-acting nicotine replacement patches, short-acting nicotine replacement gum and lozenge, bupropion, and varenicline. The other first-line meds, nicotine nasal spray and nicotine inhaler, are not currently available. This slide shows results from a random control trial where findings demonstrated why higher doses of nicotine replacement are superior at treating tobacco use disorder. Participants had blood levels of cotinine, which is a biomarker of nicotine, measured at baseline with smoking. The study then measured levels of participants on varying doses of nicotine patch to determine what percentage of their baseline nicotine level was being replaced by the nicotine patch. And you can see that 22 milligram patch only replaces 62% of baseline levels for a person who smokes 1 pack a day, 20 cigarettes. And that rate drops from there for people who smoke more. Findings from the study include that more complete nicotine replacement improves withdrawal symptoms, and it's important in initiating abstinence. A higher percentage of nicotine replacement coverage was associated with higher smoking abstinence rates up to 8 weeks. This slide shows quotes from studies that found nicotine replacement therapy to be safe for surgical patients, safe for patients with coronary heart disease, and show to not be a risk factor for myocardial events. It also includes 2 other sources that recommend use of combination long-acting and short-acting nicotine replacement. This slide shows the Mayo Clinic recommendations for nicotine replacement therapy dosing. They recommend using 2 patches for people who smoke more than 1 pack a day, even up to 2 21 milligram patches for people who smoke 2 packs per day. So for a patient who smokes a pack and a half a day, 30 cigarettes, they recommend to use a 21 milligram patch plus a 7 or 14 milligram patch at the same time. Short-acting NRT is dosed on addiction level, measured by how soon after waking up a person needs to smoke and how much they smoke. Also on the right is a quote from the Mayo Clinic stating that if a patient can safely use each of the 3 types of medications, nicotine, varenicline, and bupropion, then they can safely use all three together. Nicotine replacement, even at higher doses, is safe and recommended. People who smoke have been inhaling varying levels of nicotine for years to meet their needs without overdosing. So, given long acting nicotine and short acting nicotine together is safe. The reverse is also true. People change the way they smoke to get more nicotine when it's limited. This is shown with the increase in adenocarcinoma, which used to be rare. It's associated with the creation of light or low tar cigarette use, where inhalation didn't deliver the same levels of nicotine, so people started smoking differently to meet their addiction needs. They inhaled deeper, held the smoke longer, and took more puffs of each cigarette. With that understanding, nicotine replacement therapy should be dosed on what the patient's level of addiction is, not necessarily how many cigarettes they're currently restricted themselves to. If a patient has cut down, it's important to know if they're having to manage cravings between cigarettes, because then they're cutting down with willpower, not because they've decreased their tolerance or addiction. And as we saw earlier, that fails 95% of the time. Having the appropriate nicotine replacement dose decreases their reliance on willpower and makes it easier for them to quit. Varenicline has two actions. It blocks dopamine and norepinephrine release with smoking, so decreases the positive reinforcement associated with smoking. It also stimulates alpha 4 beta 2 nicotinic receptors to decrease cravings and withdrawals. Because it only works on the alpha 4 beta 2 receptor and not all the nicotinic receptors, patients still need the nicotine replacement therapy. Varenicline is a safe medication with no relevant drug-to-drug interactions. It used to have a black box warning for suicide, but no longer does. While there is an increased risk of suicide with quitting smoking, studies have shown that the risk isn't further increased by the use of varenicline. Ways to manage side effects is also listed. Bupropion blocks reuptake of dopamine and norepinephrine, decreasing cravings and withdrawal, and may also act as a nicotinic receptor blocker. This medication also weakens the reward from food intake, so decreases risk of weight gain with smoking cessation. It does have some contraindications listed, and ways to manage side effects is also listed. I wanted to make you aware of this resource, 1-800-QUIT-NOW. Patients can call or text for free quitting tips, support, and free nicotine products to try. These are my references. Thank you so much for watching this. I hope you found it helpful.